Welcome. I'm Lisa Van Rijmdonk. I'm the Executive Director of the School of Public Affairs Institute, and on the team of folks that loves bringing our First Friday events to you and is terribly sad that we still can't be in a room together sharing some great catering. But we are staying virtual for the rest of this, for us, this semester. So when we come back in the fall, gosh, we hope that we'll all be immunized and we'll be able to be in that shared space together. But we have planned for First Friday now in the noontime for the rest of spring. So welcome. Just a couple of quick things. The first thing I want is we have a little bit of an announcement from the School of Public Affairs, and that is about what we used to call our Bachelor's of Arts in Public Service. We fondly refer to it as the BAPS program, but our undergraduate degree program. And we are renaming that the Bachelor's of Arts in Public Administration. And calling it BAPA. We've just found that the Bachelor's of Arts in Public Administration is a lot more descriptive and clear about the kind of education that the students get in that program. I teach in that program. It's an amazing group of students who do most of their work online to get their bachelor's degree and then go off to lead oftentimes great careers in nonprofits and government or continue even their great careers. So that is our announcement. Tied to that is a CU announcement, and that is that CU Denver's free application day is on Tuesday, February 9th. So if you have any friends, family members, people that you work who work for you, et cetera, who are interested in applying to our BAPA program or any other program at CU Denver, that free application day is February 9th. So I also want to, before I turn it over to Deserai, just mention, in case Deserai doesn't, so we have two outstanding alumni on our panel. Deserai is one of them, and Scott Bookman. So we always love it when you all, as our alumni, come back and share your expertise with us, and in the case of Deserai, come back and work for us. And so thanks to those of you that are alums. I know John Fishburne has been doing a lot of great work in engaging more with our alums, so reach out, and definitely if you want to engage with us, be on a panel, etc. We're always happy to hear from you and to hear about the great work you're doing. With all of that said, I'm going to pass it over to my terrific colleague, Deserai Crow, who is going to guide us in this conversation. We are in the middle of a global pandemic. It's been a very, very long slog. I know you are probably feeling it as I am, a lot of loss, and we are still in the middle of it. And we have to get ourselves out of this through vaccination is one of the ways. So I thought we'd bring to you today a panel talking about what are the fits and starts in the ways that we are working our way through vaccination. So Deserai, I will pass it over to you.
Thanks so much, Lisa. And thanks for everyone joining us today. We have a terrific panel that we have planned to have this conversation about Colorado's COVID-19 vaccination response and the questions that surround that. I mean, over the last year, the term unprecedented is certainly overused, but obviously very accurate given the crises that our country and our communities and indeed the world face. If we think just back to March of 2020, we were learning so much about this new virus, our lives and our communities, our schools, our businesses, and truly the entire world changed almost overnight. And in those first months after the pandemic hit and COVID-19 was declared a global pandemic, governments at local, state, federal, and even international cooperative organizations like the UN and the WHO had to cope with understanding the virus, emerging science and uncertainties there, had to deal with generating tests and getting testing supplies and testing up and running on a mass scale that we had not dealt with before. And then certainly containment and understanding how the virus was transmitted. But then while we're still certainly trying to understand this virus in its entirety, if we fast forward now to early 2021, the conversation has moved, fortunately, very fortunately, to questions about vaccine distribution, efficacy, vaccine hesitancy, and also the questions of ethics of prioritizing certain populations over others. And all of these are really tough, challenging questions, not only for elected officials and agencies at the state and local and federal level, but certainly for us in academia as well. So that's kind of what motivates the panel today is trying to understand this next phase of the pandemic and some of the very challenging questions that go into this mass distribution of vaccines on a scale that is really, truly unprecedented, back to that word. So today, I'm joined by three really wonderful panelists that I'm going to introduce today, but in just a moment. But first I want to welcome, we have a number of elected officials. We have a number of state legislators in particular who are joining us today and some of their staff. So thank you for joining us. Thank you for being interested in learning and being part of this conversation with us, because we know that you're being challenged like no other time, certainly. As we start, I want to introduce our three panelists. First of all, Scott Bookman, who is, like Lisa said, an alumnus of our Masters of Public Administration program. Scott is the director of the Division of Disease Control and Public Health Response and the incident commander for COVID-19 at the Colorado Department of Public Health and Environment. Recently in our alumni magazine, Scott described his job. He said, "My job is really to oversee a response that includes our communicable disease branch, our epidemiologists, our state labs, and then our emergency coordination function for the Emergency Operations Center, looking at healthcare surge, consequence management, fatality management." This guy has a really important job. And in terms of the kind of just the logistics and understanding what a state agency copes with in ramping up this vaccine distribution process and through the whole COVID-19, I think Scott's going to have an excellent perspective to share. Next, we have Dr. Anuj Mehta, who is an assistant professor of medicine and a pulmonary and critical care physician at Denver Health. He also has appointments at National Jewish and the University of Colorado. In addition to caring for COVID-19 patients in the ICU throughout this pandemic, Dr. Meda has chaired the group that rewrote the state's crisis standards of care in the spring and chaired the medical advisory group that made initial recommendations to the state on vaccine priorities. Currently, Dr. Meda continues to work with CDPHE on implementation of the vaccine plan and educating communities about vaccine safety and efficacy. Dr. Meda also runs a research program funded by the National Institutes of Health on shared decision-making in ICUs. So an excellent perspective that we're looking forward to hearing from Dr. Meda today. And finally, Dr. Katie Dickinson's an assistant professor of environmental and occupational health in the Colorado School of Public Health and a JPB environmental health fellow. Her research examines how people perceive and respond to risks, as well as the impacts of policies and programs on health and social outcomes. Her past and current projects have addressed problems at the nexus of environmental quality, economic development, and human health, including water and sanitation, energy and air pollution, and mosquito-borne diseases. Environmental justice is a central focus of her work. And with regard to COVID-19, Dr. Dickinson is working with the Risk and Social Policy Working Group, which I'm a part of as well. And so we've had the pleasure of working together to understand individual and policy level responses to the pandemic, including examining vaccine attitudes and public trust in institutions and the role of structural racism in our public health response to COVID-19. So thank you all for being here. I want to, we've asked our panelists to kind of give us an overview of kind of their perspective on the COVID-19 response and vaccines. So Scott, if you wouldn't mind taking it away.
Great, thank you, Deserai, and thanks to everybody for joining. It's funny, you started talking about last March, and it was, you know, the trauma of the last year for all of us has come back. We keep using unprecedented because there's no other word, and there's no set of words that are big enough to really describe what we have all been through over the last year. And I want to take a moment before I even start talking about this to recognize Dr. Meda and the thousands and thousands of healthcare providers across our state who have been on the front lines of this. Well, it has felt like a long year for everybody out there. And while it has certainly felt like a very long year for me, I have had the ability to, do this work from the safety of my home, from the safety of my office. And, you know, our frontline healthcare workers, our healthcare leaders deserve an amount of gratitude that is hard to describe. What they have done for our individuals and for our state over the last year, and will continue to do for quite some time, is remarkable. So I just want to take a moment to acknowledge that. You know, everything up until December 14th was the largest public health response of a generation. And then on December 14th, the first dose of vaccine arrived in Colorado. And then we added what is now the largest health response in the history of public health to the work that we are doing. You know, and I think it's important to, you know, acknowledge that we have all been doing this work, this incredibly difficult work, for a year. And, you know, you look at what's happening in California right now. And, you know, LA County is struggling to mount a vaccine response similar to what we're doing in Colorado. Well, their hospitals were just overflowing. Their hospitals were just running out of oxygen. And so, you know, I'm not here to make any excuses or to ask for any grace, but it's important as you frame this decision making, as you think about the work that's going on, is all the people like Dr. Meda who have been on the front lines for the last year are now also the people who are tasked with partnering with public health and doing this vaccine effort. And so this is a truly monumental undertaking, to say the least. In an ideal world, we would have had 5.7 million doses of vaccine show up on December 14th. We would have been able to administer them over the course of several weeks. We would have had the second doses arrive 3 to 4 weeks later, depending on what vaccine we had. We would have been done, and we moved on. We got 35,000 doses in our first week. We got 96,000 doses in our second week, and then it receded. And we've been receiving somewhere between 50 to 70,000 doses of vaccine for a state of 5.7 million. So when you're faced with that, you are faced with the incredibly difficult decisions of prioritization, and you are faced with the incredible logistics challenge of figuring out how to target this vaccine every single week as it comes in to serve those who need it the most at that given moment, knowing that you can't meet the needs of almost anyone, given that incredibly limited supply. And so the framework that we used in our response was really based on saving as many lives as possible and ending the crisis as quickly as possible. And so when you look back at what has transpired over the last year in COVID, we know that 78% of our deaths have been in those who are 70 and up, and 40% of our deaths have occurred in those who lived in nursing homes or assisted living facilities. And so that was really the framework that we used to come up with our prioritization, and really how we came to the fact that our frontline healthcare workers and our residents and staff of nursing homes and assisted living facilities were at the top of that priority list. And so, you know, in some ways, it actually made the initial decision making and the initial operationalizing of this relatively simple. Vast majority of our healthcare workers, work in large healthcare systems. That initial 1A group was really focused on, ER, ICU, respiratory therapists, COVID-specific units, those who were at the absolute highest risk of contracting COVID through their work. Right? So that was one half of 1A. And then obviously the other half was the federal partnership for nursing homes and long-term care facilities. And so, we were able to really parse out our work there, and it made for a really efficient process. And we were rapidly able to move through the vast majority of those frontline healthcare workers. As you start pulling back, it obviously gets increasingly complex, at a much higher rate. As you start thinking about how do we get, all of our family practice docs, how do we get, a cardiology practice that has 2 providers in it? How do we hook them up with healthcare providers? Because this isn't a vaccine where you can send one vial to one provider and they can keep it on hand. Right? This requires either ultra low freezer or comes in boxes of 1,000 vials. And you're really trying to work through distribution and then redistribution. And we want to make sure that this vaccine is used as rapidly as possible so that it's not sitting on a shelf, because every day matters. right? Every minute matters. The faster we get vaccine into arms, the more lives that we save, and the quicker we can move on to getting society back to normal. And so, these are the difficult logistical challenges, the difficult prioritization challenges that we have as we work through every single phase of this. And so we're now looking at an interesting spot where we're moving out. We've added 70 plus. Our target is to have 70% of 70 plus in Colorado vaccinated by the end of February. We're moving starting on Monday, where we're adding 65 to 69 and also adding PK through 12 educators. We're still pretty resource constrained right now, but we're starting to hear some really promising news. Pfizer is going to be increasing their supply. Moderna is going to be increasing their supply. Johnson & Johnson, the Janssen vaccine, they just submitted their EUA. We anticipate that by end of February, we're likely to have that approved. And by early March, we'll have that vaccine in hand. And so while vaccine is going to stay incredibly constrained right now, we're planning for a world where by March, April, ideally, depending on federal supply, we could have the opposite problem. We may have so much vaccine, we may not have enough people to actually do the vaccinating. And so now we're looking at developing our plans for our large scale points of distribution, right? And how do we set up large sites across the state? How do we have targeted sites in hard to hit neighborhoods, making sure that we're doing all that we can. We feel like we've got about a 6-week run up to where all of a sudden there could be enough vaccine here that, instead of being constrained by the supply, we're constrained by those who can administer it. And so that's really where we are at this point. I think we're doing transition planning. We're looking at what our educators going to look like next week. What does it look like as we get into early March? But then really also looking into what does this look like later into the spring and later into the summer when we have this massive amount of vaccine and we really want to move towards rapid administration to as many people as we can, as quickly as we can. So Deserai, I'll turn it back over to you. I think that's a summary of where we are today.
Wonderful. Thank you so much, Scott. That's hopeful news that the vaccine numbers are going to ramp up quickly and that there will be other constraints and challenges, certainly, but that is hopeful. Dr. Meda, I would love to invite you to give your perspective next and your thoughts on the current challenges.
Sure. First, I want to thank Scott. Scott is a former EMS provider, so he is a healthcare worker. He's been doing this work for a long time. And, Scott's right in terms of thinking about where we are in terms of everyone else. I mean, obviously, we would love to have had 5.7 million doses on day one, but Colorado is one of the top 5 states. We are using our supply. We are getting to the people that need it. And obviously there are things we always want to improve. When I take care of a patient in the ICU, there's always things I think I can do better. And we're learning from that. But really, I think CDPHE and all of Scott's work are why Colorado is as well off as it is, which is really fantastic. And I think that's due to some really long hours that Scott and his team have been putting in and others along there. So I'm just going to share my screen really quickly. And trust me, this is not going to be a lecture. It's just a couple of slides to show how I think about things. I always think of COVID-19 vaccines as kind of the worst line to wait in. We all want it right away. And so the perspective I want to offer, for no financial disclosures, I don't get paid for any of the vaccine work I do for the state. It's all kind of what I think we need to do to make a difference. So my perspective is much more, the GERC, which is the Governor's Expert Emergency Epidemic Response Committee, convened a group of medical experts to offer recommendations to the state government on priority populations. And it was fully understood that these were going to be recommendations and they would have to be modified based on the realities of doing this mass vaccination campaign, like boxes of shipments that were 1,000 instead of 5. We went through a process over the summer to generate the recommendations on how to decide priority populations. And we considered a few different things. The biggest thing we considered was ethical principles, but there's also logistics, and then there's gut instinct. And I know the gut instinct is kind of like a nebulous term, but we all feel it, right? We may not be able to articulate why we think children should be prioritized for something, but we all feel that inside. And it's important to listen to that, because when we, in 10, 15, 20 years, when people evaluate our response, they're going to be thinking about that too. But we focused really on kind of the core ethical principles that should dictate priority populations, and specifically who should be prioritized over the general population. And I don't want to get into the specifics of who goes first and second and things like that, because that's kind of where there's academic debate and also the realities of the pandemic influence it, but really who should be prioritized over the general population. And first, there's a statement about who should not be denied a vaccine. And I'm not saying shouldn't be prioritized or not, who shouldn't be denied a vaccine. This was in our recommendations, and I know everyone in the state, and especially the governor, has really endorsed this, that none of these reasons are a reason: gender, race, ethnicity, ability to pay, disability status. These are core reasons never to enter your mind as to who gets a vaccine and who doesn't. And I think we've been following through on that really closely. And also kind of not making decisions based on VIP status, which is something Colorado and I know the executive branches really believes in. So Scott really hit on kind of that number one principle: we want to save lives. That is obviously one of the most critical things we can be doing as a healthcare worker, taking care of patients in the ICU, people in front of me. That's what I want to do. It's not the only thing we consider. And when we think about who's in 1A, the healthcare workers, right? I have a very low risk of dying from COVID. There are other reasons to consider putting me first, but it's not necessary to save my life. And so both our group considered multiple ethical principles, and those same principles have been considered by the WHO, the National Academy of Science, Engineering, and Medicine, and also Johns Hopkins School of Public Health and others. So we need to maintain critical societal function, and that's kind of where vaccinating healthcare workers comes in. We want to think about who's at high risk of exposure through essential work, who is high risk of transmitting it to others, who's going to perpetuate the pandemic. We want to think about ending the crisis, as Scott really said, and all three of those are kind of linked: high risk of exposure, risk of transmission, and ending the pandemic. We think about the multiplier effect, and that's kind of an ethical principle where by protecting one person's life, that person can go on to save multiple others, and that's also kind of where healthcare workers play in a role. There is a concept of reciprocity, and I list that not because it's what we operationalize, but because a lot of people have considered it. People that are on the front lines who are being exposed through the very essential work, they're showing up for work, thinking that they maybe should get some degree of priority. And then a big thing for, I think, all of us is recognizing how terrible this pandemic has been, and in terms of inequities and communities of color, and thinking about equity. So that translates into populations, actually. Right, healthcare workers serve a critical function. They have a multiplier effect in saving others' lives. Think about reciprocity, high risk of exposure, obviously. And then we know that certain types of healthcare workers, specifically those who are not physicians and nurses, so people working in long-term care facilities, home health aides, tend to live in communities of color, actually, and they tend to live in multi-generational homes. And there's really strong data that they live with people who are at high risk of dying. So it could be a 30-year-old home health aide who lives with their grandparents. And so they're getting exposed at work, they're coming home, and then they're getting their grandparents sick, and their grandparents are likely to die. So one, that's why, their grandparents are phase 1B1 over the age of 70. But also, that's also why we had a really broad definition of healthcare workers. And I think both CDPHE and the governor's office has really endorsed this idea that we need to be broad when we think about healthcare workers. Frontline essential workers, the same is very true about grocery store workers and people working in transportation and teachers especially, that we know that they have to serve an essential function, high risk of exposure and transmission. There's a reciprocity because they're showing up and doing the work. And there's a big equity component. And I really want to highlight this because I think this is something, when we drafted our recommendations, this is something the governor's office really, I think, took hold on and implemented as part of the plan. It's why as frontline essential workers are on 1B3. And it's something that actually ACIP, the CDC's branch that organizes this, I think really, they read our recommendations and I think it influenced their recommendations. Essential workers, frontline essential workers are more likely to belong to communities of color. And as I said, more likely to spread the virus to people at high risk. And there's a view of structural racism that actually reinforces this. Right, they're more likely to live in multi-generational homes or high-density locations due to historic redlining practices. And they're less likely to have access to care. So the idea of prioritizing people who are at high risk of exposure kind of feeds into those ethical principles. And you can see some of the other groups in kind of adults, prioritizing nursing home residents. We're going to save the most number of lives. Adults with comorbidities, we need to save the most number of lives. And we also know that, our communities of color who have been disproportionately hit by the pandemic, they're more likely to have diabetes, obesity, and that's kind of why they're in phase 2. So a lot of the phased approach really takes into account these ethical principles. And in terms of our recommendations that we made back in October, there was an equity lens to each one of those phases. And I think that that's really what, at least at an ethical level, kind of bears out in terms of what we're really attempting to do. One of the circles was logistics, and I think Scott obviously hit on the biggest issues, right? Like 1,000 doses, 1,000 doses per box, right? So how are you going to get that to the individual who is working, who's working in a private practice with only 2 workers? So there's logistical issues there, but there's also logistical issues in terms of matching the supply with increasing eligibility. And so healthcare workers are a relatively small population. Essential workers are a bigger population. High-risk individuals are, even though we have a really healthy state, still about 2 million people. And then you think about the general population. And as we expand our eligibility, as we expand our supply, we want to expand our eligibility. But it wouldn't make sense on an ethical level to prioritize high-risk individuals first when we have exceedingly low supply, because we'll have such a shortage that it'll only worsen some of the inequities that we've seen in the delivery of care. And so this played into some of our recommendations, like not driving force in terms of the size of these populations, but it did play an impact in some of the recommendations we made. So like I said, pretty short slide, but just kind of highlights kind of the thought process that we did. And I think a lot of other groups mimicked what we did.
Wonderful.
I'll turn it back over to Deserai.
No, thank you, Dr. Meda. That's a fantastic lens through which we can have this discussion about equity and distribution of the vaccine. Thank you. I'm going to ask Dr. Dickinson to go next and give your perspective. And I know some of the things that I mentioned in your bio are particularly interesting to you with vaccine hesitancy and structural racism and so forth. So if you wouldn't mind taking it away.
Absolutely, thanks. And yeah, thanks for the opportunity to be on this panel. I'm learning a lot, and I'm excited to have this discussion. So I want to make 3 points in my sort of intro comments right now. The first, which shouldn't be a controversial statement to the School of Public Affairs, is that the pandemic is a social and political phenomenon as much as a medical and a public health one, right? So we need interdisciplinary, multi-sectoral teams leveraging diverse types of expertise in order to address it. And I have been fortunate enough to work with such a team. As Deserai mentioned, we formed the Risk and Social Policy Working Group early in the pandemic back in March, and have gotten funding from the National Science Foundation and the National Hazard Center to look at this problem from an interdisciplinary lens, taking approaches from political science and economics and risk communication and public health. So the second point that I want to make is that when we think about, so my comments are going to focus a little bit on the sort of perceptions and attitudes toward vaccines. And we want to think about this in terms of a spectrum, okay? So there's a wide range of attitudes toward vaccines that range from, extreme eagerness to outright rejection. This is complex, it's multifaceted, and it's driven by a number of different factors. I also want to say that, how we talk about this issue is really important. One of my mentors, Dr. Lee Newman at the School of Public Health, has, cautioned me about using the term vaccine hesitancy, because it really does focus on this one end of this really complex issue and sort of plays into this sort of controversy narrative where there's a lot of nuances, really. So in the first project that our team conducted, we surveyed a set of people across 6 states in May, August, October, and December of 2020. And we found that individuals' attitudes changed over time, right? So people weren't fixed in their opinions toward this vaccine. And these changes were related to a variety of different factors. So they were related to political ideology. And so, from that lens, right, the factors that are driving concerns about the vaccine among conservatives versus liberals were quite different. So conservatives, right, months of being told that the pandemic was a hoax and not something to, just like the flu is just going to go away. Whereas among liberal respondents, I think there were a lot of concerns about the politicization of the vaccine development and distribution process. And so we see, for example, that after the election, the eagerness for vaccines sort of ticks back up among liberal respondents, less so among moderates and conservatives. But what I'm going to focus, the rest of my comments on today really is just this question of racial differences in vaccine attitudes and COVID outcomes. And so our data really confirm this well-publicized fact that there are differences in vaccine eagerness across racial groups, with Black respondents consistently less eager than white. This is confirmed in our second study, which we have just started. So in this second project, we started a nationally representative sample of a survey of racially stratified samples. So we're equally sampling Black, white, and Hispanic respondents. And we just finished the first wave of that survey. So again, we're confirming that the percentage of white respondents who say, yes, I will get the vaccine definitely, is significantly higher, 3/4 of white respondents versus about 40% of Black respondents. And similarly, attitudes towards the vaccine, other attitudes toward the vaccine, so perceptions that the vaccine is safe, and perceptions that people of their race are being treated fairly by the healthcare system. So it's really important to emphasize that, as Dr. Meda noted as well, right? This isn't coming out of nowhere. These attitudes are really embedded and following a deep history of systemic, societal, and medical racism and abuse. This abuse goes well beyond, that one highly publicized thing that happened in Tuskegee, and includes, things like eugenic control of reproduction, gynecological experiments on Black women, radiation experiments. Dr. Harriet Washington has a book called Medical Apartheid that really delves into a lot of this deep history. So not surprisingly, right, this has given rise to some deep mistrust of the medical establishment in communities of color. We also see differences in policy support, and I'd like to in the comments kind of get into some of these conversations around mandates. So I'll leave that there for now. And so, the concern here, right, is that this is, despite a lot of attention and conversation around this topic, we are already seeing that the vaccination rates are different along racial lines. So if we just look at Denver, we're seeing higher rates of vaccination in neighborhoods that are predominantly white than in neighborhoods that are predominantly Black. And so the strategies for addressing this issue are multifaceted, are going to need to be multifaceted as well. And just the last point that I want to make here is that, while we are living in an unprecedented times, it is not entirely unprecedented, right? So we have dealt with other situations where we've been trying to distribute vaccines to the population. And so we can learn from other contexts and interventions. Dr. Noel Brewer at UNC has done a review of vaccination studies that shows that interventions that directly address barriers and make it easier to get the vaccine, such as by providing vaccines at workplaces, may be more effective than strategies that are really focused on trying to change people's opinions and kind of the hearts and minds kind of approach. Dr. Sandra Quinn at the University of Maryland has done a lot of work with flu vaccines and Black populations. And she suggests that, while there's a high distrust of the medical establishment overall, there is a significant amount of trust in individual providers. And so working with providers, with community health centers, may be an effective strategy in this case as well. The thing that I do want to kind of throw back to the rest of the group is this kind of question of, when we do see these racial disparities playing out, how much can we hope that a race-blind approach to the problem is going to solve a problem that is fundamentally tied to structural racism? So if we are not specifically saying, we are going to prioritize communities of color in a concerted way, while there are correlations with frontline workers and other factors, that's not necessarily naming the root of the problem and devising a strategy to get at that. So I'd love to talk more about that as we discuss.
Great. Thank you so much, Dr. Dickinson. That's really terrific perspective. And I think that combined, the points of view that you all bring to this discussion are kind of a perfect complement for getting our Q&A and our conversation going here. I have a couple of questions that I'd like to ask you all before we kick it over to our audience today. I'm wondering if we, from any of you, if there are certain states or nations, even local governments, particularly with some of our larger cities, that Colorado is looking to or should be looking to in terms of who's doing it well, or I guess cautionary tales though as well, but certainly those who are using best practices, who are seeing incredible success. If you could tell us anything about what you're seeing outside of Colorado as well.
I'll let Scott answer, but I would like to say, I think a lot of people are looking to Colorado and Scott and everyone's work because we're actually doing really well in comparison. But I'll let Scott answer. That was just a shout out to him.
That's great to hear.
Thanks, Anuj. We are. I mean, Colorado is performing very highly compared to, many other states in the country. I attribute that to, number one, just this incredible partnership that we have had from the beginning of this pandemic with our healthcare providers. And so whether it's been our hospitals, our federally qualified health centers, our local providers, I mean, we've built those relationships and they have now paid off in the vaccine effort. Number two, we started working on this over the summer and building out an incredibly large team to prepare for this. We brought in the Colorado National Guard, Brigadier General Scott Sherman. This is a massive logistics effort. And so when you start talking logistics, the presence of the National Guard to support us in that effort has been really critical. I think where we've also succeeded, and I think other states have really struggled, is, we're really stressing appointments and not just first come, first serve drive up clinics or, walk up clinics where you just see these horrible lines. And, that is going to discourage people from coming back to get their second shot or even to wait and not get their first one. And so, I think that's been a really strong strategy as well.
I would like to add that the first come, first serve that's been used in other places for mass vaccination settings, while working in the future potentially, really drives a lot of inequity, right? Drive-through clinics discriminate against people that don't have cars, right? And so this idea of setting appointments so that everybody has potentially equal access. And I'm not going to say there aren't problems, right? Like the primary push has been a technological push of like email appointments and stuff. And so the state has been expanding the capacity for the new COVID hotline. But again, it's like, right, you start with 50 people and you can't wait until you have 200 people. You got to start somewhere. And I think that's, that goes into it. I also think that there's been a lot of community engagement that maybe hasn't been highlighted as much. And this is going through from CDPHE. And while we're a long way from equity, and this is just one step in the process, and we already know that there's inequities in the vaccination numbers for the state, and that's partially because of hesitancy and that's partially because of access. But there is really, from the get-go, from Crisis Standards of Care, there was a community engagement group that was set up at CDPHE that I worked heavily with in drafting the Crisis Standards of Care. And then moving on to Vaccine Priority, we re-engaged them. And now CDPHE has a Champions for Vaccine Equity program where literally any group that wants to get information about the vaccine can call, and they'll get a medical professional that'll virtually show up and give a talk to anybody. I gave a talk a couple of weeks ago to a group of dairy farmers through their employer. And it's just like, I think that type of work is going to be really decrease hesitancy amongst people who are hesitant, not anti-vaxxers, because I mean, they've already made their decision, but decrease hesitancy. And I think that's another thing that Colorado's done really well.
Thank you so much for those perspectives. I think that I'm curious also, we hear in news coverage in particular and anecdotally that many states have really struggled with federal-state relationships over the past year, and even still. And obviously we've heard high-profile examples of that with New York and others. My impression is that Colorado has done fairly well in this regard in terms of both our state elected officials in the governor's office, our congressional delegation, and the relationships with the administration, and trying to just get the logistics and so forth. Is that impression correct? I guess, Scott, if you might be able to speak to that.
Yes, I mean, there have been challenges at the federal level, at the state level, the local level. I mean, communication in something of this size has obviously been, a challenge. I think in the early days, we were obviously very surprised by, kind of the inconsistent information coming out of the White House and out of the federal government. I think Governor Polis has never been reluctant to pick up the phone at any point in this response, and has made many phone calls to, federal officials across the board. And I think we have had really good open communication to the best of our ability and to the best of their ability with the federal government. We then had just as much communication with the Biden transition team, and kept that communication going both with the outgoing Trump administration and with the Biden transition team. And then literally the day of the inauguration, by 4 p.m., we were already on a call with the Biden team talking about this. This is hard. And it is just as difficult for the federal government as it is for us and for our local partners. But I think that, Governor Polis, our federal delegation, our state electeds have all done a really wonderful job of keeping that communication going between the state and the federal.
I think that's one thing. And Katie, maybe you can speak to this a bit. One of the things that, best practices in crisis communication talks a lot about consistent and clear communication, how important that is to have simple, clear messages. And the consistency of communication has, I guess, ebbed and flowed over the last year, certainly. And I wonder if you can speak to, Katie, just kind of the messages coming out of various levels of government, and if you're seeing any connection between that and risk perceptions or vaccine hesitancy or any of those kind of questions that you're looking at through the surveys.
Yeah, I should throw that back to you since you've been looking at the policy side of things a lot more. I guess one quick response to that is just that, we do see a lot of variation again in this hesitancy or, eagerness across states. So I think that this, that the consistency does matter a lot. And I think that, I don't think it's a controversial statement to say that that was a huge blunder and missed opportunity to drive the country in one consistent direction. So, if there's something that makes me hopeful, it's that at the federal level, I think that's changing. Again, when we talk about racial disparities, I mean, it's been really heartening to me to see how the incoming administration has, talked about the linkages between, the need to incorporate racial equity into the vaccine or into, COVID response and, climate change, like all these different priorities, like mention, talking about those interlinkages and how they need to drive together. I give yourself a moment to talk about any of those so our team's really great, and we've got, Deserai is leading a team that has been really tracking the messaging and the policies coming out across different states and looking at that side of things. So she may have a
I do think thanks, Katie. I think that that consistency, it varies significantly by state to state, not only how kind of consistent the governors and the state departments of public health are, but also just simply how much information they're trying to push out to the public. And Colorado is certainly on the leading edge of the amount of information and the amount of communication, kind of proactive communication coming out of state agencies. And so that's, as a Coloradan, that's heartening. Certainly, I think that just in terms of that effort to communicate widely, to communicate often, and very proactively, I think Colorado is one of the leaders in that regard. So That's certainly something we're seeing in the messaging studies that we're doing. I think before I turn it over to a couple of some of the questions from our from those who've joined us on the webinar today, we've had a couple that I've noticed come through the Q&A function and the chat focused on kind of this category of questions around, haven't we been preparing for a pandemic for an awfully long time, back to SARS and MERS and Ebola and so forth. Both Republican and Democratic administrations have been planning for this and have put laws into place for public health preparedness and so forth. Are there failures that can be pointed to, as far as you all have seen in your various facets of this work, that either on, kind of an institutional level, for example, the medical field or CDPHE and agencies like it, or on the federal level, that really those were missed opportunities, or we need to make some changes so that this doesn't happen again? Where were those failures or those weak points in this response?
Go ahead, Anuj. You beat me to the unmute button. You go first.
I think that on a very conceptual level, the United States opted a long time ago to not have a strong federal unified public health system. Public health is a local thing, which makes a lot of sense when you think about what the public health things that we've been dealing with, right? Contaminated water in a specific county, animal outbreaks of disease, right? We have random cases of the plague actually in Colorado, and that makes sense for Colorado to deal with versus Lyme disease on the East Coast. But as a result, it's been really hard to think about how to design a response for a federal process. Hence, my opinion, there was no federal unified response for the first part of the pandemic, actually. And I think that had a lot of trickle-down effects. I also think that, because we haven't faced a public health nightmare in a while, public health budgets have been cut for the last 2 decades. And so, there are certain counties that are operating with 5 public health workers for a certain population. And so that's happened at the federal level and throughout. And it's everybody, right? There are multiple competing priorities for a limited number of funds. But I think that's something that's highlighted, and it also highlights, planning can only go so much, right? Like, I can sit in a room and plan on a board all I want, and one little thing, like the fact that everybody needed a ventilator, which is a really scary thing. But like the amount of people I took care of on a ventilator between March and June exceeded the last 5 years of my career. And so that's something nobody would have ever expected, or similar things like that. That's not something we necessarily saw with SARS or MERS. And this idea of like school closing, right? Like that's something nobody like really thought of. Like, oh my God, what are we gonna do with all the kids that are home? So I think it's just recognizing what some certain things that are impossible to plan for.
I would almost say that we lacked imagination in our planning and preparedness. So this is a disease that wound up having, 40 to 60% asymptomatic transmission. We didn't plan for a world where it started in the place where most of our PPE is manufactured. And so, who thought that PPE, Q-tips? I mean, in the beginning, we couldn't do testing because of a lack of swabs, right? And so I think that my biggest lesson learned from this is we just didn't have enough of an imagination. Those who have done exercises, we always joke, right? Eventually, the asteroid falls out of the sky when you're doing some crazy tabletop exercise, right? Everything that you would have said in a pandemic tabletop exercise couldn't happen has actually happened here. And I think that for me, going back and thinking about how do you plan for the next one is all based on, well, what happened in COVID and how could it be 10 times worse?
I'll throw one other thing is, early on, there was a lot of conversations about the strategic national stockpile. And so that was a lot of planning, or it had, ventilators, it had pharmaceutical, had PPE, but that was designed after 9/11 in response to a potential bioterrorist threat, which is a local event. And so that was the other thing. It's like, do you think of something that hits everything so badly initially episodic, actually. In the spring, it was New York and California and a few other places that were really, I mean, we were overwhelmed as well, but nothing on the order of that. Now we're in the winter where everyone was a disaster. And how do you model that? And I think that's, that's something that also we just plan for potentially a little bit of a different scenario.
Yeah, that's terrific. Katie, do you want to add any final thoughts before we kick it over to the audience for questions?
I think I'm excited about audience questions. Go ahead.
Anuj and Scott, one question is, as new vaccines are approved for distribution, there will be significant differences in efficacy, in the supply between the Pfizer and the, what have you. Will the state make different plans for distribution based on the efficacy of those vaccines? So for example, will vaccines with higher efficacy be targeted to high-risk populations, whereas the lower efficacy might go to the general population?
So I think it's too soon to say. And, let's start with the fact that the efficacy of all of the vaccines that have gone for EUA at this point are still more effective than the flu shot. The annual flu shot is between 40 and 50% efficacy. And so, what we're talking about here is degrees of such, which is still an incredibly effective and safe vaccine. Number one, we are hoping for some federal guidance on this that may help us have a national approach about how we'll utilize all of these vaccines in concert. If that does not come, we are preparing for it. And we are thinking about things that, do take efficacy into effect, but given that they are all highly effective, we then think about things like 1 dose versus a 2-dose shot, and what population is less likely to come back for their second, the storage requirements. And so to me, a lot of this is logistics along with that efficacy. But Anuj probably has other thoughts as well.
I think all of that needs to be taken into account, and I'll speak specifically to the data from Johnson & Johnson, which, they released a press release. That's all the data we have right now is a press release that highlighted 66% overall efficacy. So still better than the flu shot, 72% in the US because we don't have the South Africa variant running as rampant, and that's what really dropped the efficacy. But really interestingly, they're doing a 2-dose trial right now. And it might have 95% efficacy if you do 2 doses of the Johnson & Johnson. We don't know. And it also showed fantastic ability, potentially better than Pfizer and Moderna, to prevent severe infections and death. So while maybe, and this is like an interesting statistical and medical property, while maybe lower overall efficacy may be better at saving more lives. So do you give it to lower risk people because the overall efficacy, or do you reserve it for the high risk people because it's more likely to prevent them from dying? And I think what we need to do before we spend too much time pontificating, because I can pontificate to no end, is wait to see the robust data. And then I think maybe we'll sit down and do a very similar thought process with some medical experts in Colorado, but also look to ACIP and the Advisory Committee on Immunization Practices. They're the ones that give this type of advice. And hopefully we see a system where we try and follow on a federal level what that advice is, which wasn't the case, I think, with the initial vaccine rollout in a lot of states.
That's really interesting, the difference in terms of how we talk about efficacy and so forth. Katie, we have one question that says, does Dr. Dickinson's slide showing hesitancy in some racial groups contribute to lower vaccination rates as well? Or are they, kind of still going and getting vaccinated despite those concerns?
So it's a really good question. And I think, what we're hoping with our, again, starting a new panel study where we can, be following up the same people over time. So if we've got this group of respondents who, told us how they were feeling about vaccines in January, and we're following them through May or so, we're going to see a significant number, hopefully of increased vaccines, and we might be able to look at that. But I think the thing that I really want to emphasize here is that it's very, very important that we don't use this data about, hesitancy as an excuse or to blame communities of color for low vaccination rates. I think we've already seen that quite a bit in the pandemic, that we see these disparate COVID, case rates and hospitalization rates and death rates, and make assumptions or make explicit statements about how this is because, the former Surgeon General said, you need to stop using drugs and alcohol and, do it for your big mama. Like it's an incredibly racist and counterproductive approach to look at these disparities and attribute those to choices that folks are making. So yes, I think it is likely the case that, again, in our survey data, we asked people what would make them more comfortable and, about the vaccine. And just quickly looking through some of those responses in the data, we do see, I do see a lot of Black respondents and Hispanic respondents saying things like, I'd like to wait and see how this affects other people. And so I think that there is this balance between prioritizing communities of color, but also being sensitive to the perception of, experimenting on communities of color. And so I think it's a thorny issue. But again, I think that understanding the historical roots of the mistrust that may be driving is likely driving some of this hesitancy and failure to get vaccinated in some communities. Shouldn't be understanding that history should drive our attempts to counteract that and really engage in productive and ethical and meaningful ways, rather than just saying, well, those communities aren't getting vaccinated because they don't want to.
Yeah, that's a powerful statement. I like the way you frame that. I think for both Anuj and Katie, we have a couple of questions, and I know that on one of your slides, Katie, you said maybe let's table this for later, but this question of employers or others requiring the vaccine, I'd love to hear your thoughts on not only the ethics of that, Anuj, perhaps, but also what survey respondents were saying, Katie, in terms of their perceptions or if that influenced or kind of their responses to such a scenario.
So in some of our we had some brief conversations, and this is kind of where the ethics of it also intersect with the legalities of it. And I can't speak to the legal issues. And I've actually heard legal opinions from experts on both sides that you can't mandate it. I think from an ethical standpoint, though, you're really hard pressed to have any type of mandate when something is still technically research. So right, an emergency use authorization, it's not full FDA approval. Still technically it's still technically an investigational drug. We're collecting more and more safety data. So I think fast forward 6 months when we do have full approval for these vaccines, then I think it's like the flu vaccine, really. And I would apply whatever case law exists for the flu vaccine. Know that the state flu vaccine mandate for healthcare systems is not an individual mandate. It's an institutional mandate saying you have to have 90% of your workers either vaccinated or have an authorized waiver. I think that we'll learn a lot of lessons from whatever case law happened with that. And I think as we get further and further down the road of we've had over 30 million people vaccinated, and we've seen already a lot of what the short-term side effects are. I think a lot of these questions about hesitancy will decrease as we move further in the vaccination process.
Yeah, thank you.
Yeah, so in terms of, support, we find that a majority of white respondents were in favor of, or thought that employers could or should mandate, employers, airlines, and colleges and universities. That support is somewhat lower among Black and Hispanic respondents. I think that that's a good point that you make, Anuj, about the, what phase we're at. I've heard a lot of folks also talk about, a mandate does not mean compulsory vaccines, right? So no one is going to be, dragged to a table and jabbed in the arm against their will. It's, the idea that if in order to do X, Y, or Z, or to fulfill the functions of your job or get on this airplane, right, you have to have a vaccine. So, and again, that's not unprecedented. I mean, I'm used to traveling internationally and having to show my yellow fever vaccine card when I get off the plane, right? So that's, that's a thing that I think people could get behind, I think maybe when the vaccine's further along. And the other just, kind of ethical point, which again, I'm just kind of curious to hear if this comes up in any of the conversations you've been having, is, this idea. Dr. Kendi, Abraham Kendi wrote a great piece in the pandemic that talked about, the difference between sort of freedom from versus freedom to. So who are we concerned about the, I think we as a society think a lot about, the freedom to make my own choice about whether or not I get a vaccine, which, is one framing of freedom, whereas the other framing is, I should be free to go to my job and not worry that I'm going to get infected because somebody else, decided not to get vaccinated. And so I think these mandates and the pandemic overall, right, really play on our deeply divided notions of whose freedom we care about and in what context.
That's an excellent point.
I'll just draw, one corollary in terms of this freedom from and freedom to, because every time I see on the news, like, the example of the grocery store in Florida that doesn't require masks at all, and that was kind of all the rage. I walk in there and I always think, what would happen if I walked in there and started smoking a cigarette? Right? Like, we ban smoking in so many public places, and we've all accepted that as a reality of life, and no one fights against it. And one, it's to force protection on the person because we know lung cancer is bad and smoking increases the risk of lung cancer. But really, it's to protect everybody else in the building from secondhand smoke. And I view masks as being the exact same thing, and vaccines as potentially also being very similar. And so it's funny that, like, we harp on this because it's a pandemic that's been highly politicized, but we have multiple examples in public health of where we've instituted policies that nobody objects to, really.
Yeah, that's an excellent, I like that, that analogy. Scott, a couple of questions I'll throw your way. What percentage of Colorado's population are we expecting to eventually be vaccinated, and taking into account the proportion who cannot be safely vaccinated? And then also, what's our best estimate of how many doses of the vaccine we're going to receive each week over the coming months at this point in time?
Well, a couple caveats there. As of right now, this has not been approved for children, right? And so, at this point, children are not in the vaccine pool that we talk about. And we are updating our polling as we speak to try to get a better understanding of where people are today compared to where they were even, a month ago on vaccine hesitancy. And we're still, we're number one, anybody who wants a vaccine will have access to a vaccine, right? I mean, it's going to come, and all Coloradans will have their opportunity to get this vaccine. We're obviously shooting for 70, 80%. The initial vaccine hesitancy research that we did indicated it would be about 65% of all Coloradans were going to take this vaccine. Recent data has led us believe that it's going to be over 70%, and we hope that number keeps going up. As far as weekly allocations go, we only have, we think, the next 2 or 3 weeks of what we know we're getting, and that's going to be, in the 80 to 95,000 range is what we're being told. We don't know until it actually shows up, and we don't know until we actually get our allocation in the federal system until, about a week ahead of time. And so, but we are hearing some really exciting news, and so we're hopeful that Pfizer, Moderna, J&J, and then AstraZeneca are all going to just, come online, and we're going to have a lot of vaccines soon.
Great. Another question is there a process whereby businesses who have assets that could assist in vaccine efforts can offer their assistance? For example, if they have specialized deep freezers for vaccine storage or transportation assets, and people can help with non-medical masks and so forth.
Yeah, we are always looking for partners and for volunteers who want to work with us. If you can go to the CDPHE COVID-19 webpage, you can figure out how to go into our volunteer mobilizer, sign up to be a volunteer, and I'm happy if anybody wants to contact me directly with an offer of help, please feel free to reach out.
Great, thank you so much. Let me just double check. Okay, this is a good one I think to maybe wrap up on. We've been talking a lot about the macro level of what governments are doing, the logistics and so forth. Can we zoom in at this point a little bit more on the micro level and what individuals can or should be doing at this point in time I guess, both in terms of the broader pandemic and as we're talking specifically about vaccines today?
So, I've been doing a ton of vaccine education talks, and I end every talk with whoever I'm talking to probably is not in line to get the vaccine today. So mask wearing, social distancing, staying home if you're sick, washing your hands frequently, those are core things. Even if you've been vaccinated, you still need to do those things because we actually don't have firm data on the vaccines reducing asymptomatic transmission. So the best example I use is I've had both of my doses of the Pfizer vaccine, and I walk my dog and I'm wearing my mask even though I'm alone, just in case I meet somebody. And I think that's kind of the personal level of responsibility. I think the other thing is that, you know, as the vaccines become more kind of available, people are going to start thinking they don't need to do those things because everyone else is vaccinated. And so again, wear masks, socially, all those things. We all want to travel. We all want to go see loved ones. And I think we're close, but we need to kind of listen to those core public health measures and realize that there have been hiccups every step along the way with the pandemic. It's unprecedented is entirely the right word. I am nervous about drops in vaccine efficacy with some of the variants, and not so much the UK variant, but specifically the South Africa variant. Vaccines may still work, but I'm nervous. And so I think we need to kind of still be careful until the science catches up to kind of tell us that we can all go back to doing the things that we really want to do.
Katie or Scott, does anyone have any last thoughts as we wrap up today? This has been a really excellent conversation and I've enjoyed it a lot. I know our panelists or our audience members are chiming in saying thank you as well.
Well, thanks for having me. And I would just add on to what Dr. Meda said. You know, it's important that people also wait their turn. And that, you know, this phasing is done for a reason. And yeah, we all want to get it as soon as humanly possible to go back to our normal life. You know, and we're using mostly a self-attestation process because that reduces barriers to those, you know, who can't have an ID or don't want to, you know, I mean, we're trying to reduce barriers for all the equity reasons, but it gives place for people to try to jump the line. And just a reminder, we are all in this together. Everybody's going to have their opportunity to get this vaccine. If it's not your time yet, it's not your time yet.
Yeah, those are great points. And I would just say, yeah, I think, you know, stay vigilant and tuned in and look for opportunities to speak up for equity. I think that, you know, in whatever capacity you can do that, you know, I think continuing, you know, I really see the education that I've been able to do over the course of this pandemic in, you know, these systems of oppression as a key part of my response to the pandemic and all of the things that it is intertwined with.
Yeah, that's great. I mean, this idea, this lens to think about the pandemic is we're all in this together and we all have our own personal responsibility, not only to keep ourselves and our families and our communities safe, but also those roles that you might play in speaking up or helping educate or all of the things that our panelists have talked about today. So thank you all to the three of you, Scott, Anuj, Katie, thank you for being here today and sharing your expertise and your perspectives. I think this has been truly wonderful. I also want to thank Lisa and Emma who organized this panel today. It's been really a terrific conversation. I know that our Dean, Paul Teskey at the School of Public Affairs would also want to thank everyone for being here. I want to also give you a little primer for our March 5th First Friday talk. Will be about the future of higher education in Colorado. And so in particular, as I think all of us in the university community, we've been talking about how the pandemic affects the university. Certainly that's been huge. Online classes. It sounds like we might have another stimulus package coming to help out state and local governments, which will certainly help out the university system. But here in Colorado, higher education is one of the CU system, I think, is Colorado's largest employer or one of our largest employers as well. So higher education means as much about education as it does about Colorado's economy. Not that I'm biased at all. So I want to just give you that idea. But thank you to all of you for being here, and thank you to our panelists for making this a wonderful conversation today. So on behalf of the School of Public Affairs, hopefully we'll see you next month, and thank you for your participation.